Good evening, everyone. Welcome to our classroom series. Today we have Dr. Keyur. He's a neurosurgeon in NIMHANS. He's a senior resident. And we have Dr. Prachi, who's a neuroanesthesia consultant. So we are going to have a discussion on cerebral venous thrombosis. So first, Dr. Keyur will be discussing the anatomy aspects and the surgical aspects. And Dr. Prachi will be dealing with the ICU management and the medical management and the ICU critical care part of the cerebral venous thrombosis. Over to you, Dr. Keyur.
So, good evening, everyone. So, today we'll be talking about the cerebral venous sinus thrombosis. Before we move on to the cerebral venous sinus thrombosis, we need to understand the anatomy. The cerebral veins are divided into five parts. So, there is superficial supratentorial cortical veins. There are dural venous sinuses and veins, meningeal veins, deep veins, and posterior fossa veins. These are the four parts of the cerebral venous system. The peculiarities of these veins are they are not having any muscular tissue, there are no valves, they lie in a subarachnoid space, they pierce the arachnoid matter and the meningeal layer, and then they finally drain into the venous sinus. So when these sinuses receive the cerebral veins, they are draining into finally the internal jugular veins. Now, amongst the dural sinuses, we have the six dural venous sinuses: the superior and inferior sagittal sinus, straight sinus, transverse sinus, tentorial sinus, cavernous sinus, and superior petrosal sinus. So this is the diagram from Gray's Anatomy. So we can see that this is the superior sagittal sinus, and the superior sagittal sinus is having drain from all the sides cortical surfaces. Around 8 to 15 cortical veins drain on either sides into the superior sagittal sinus. And mind you, as we go from anterior to posterior, there is an acute angle of these cortical veins with respect to the superior sagittal sinus. So in the front, we can see that they are almost at 90 degree, and as we go back, they will be coming at an acute angle. This is important because when we are dealing with surgery of these surface of the brain, we need to be careful that these veins that we are going to handle, they will be at an angle, and managing the brain around these veins is little tricky. Coming to the confluence of sinuses, the superior sagittal sinus in 60% of the cases drains towards the right side transverse sinus, whereas the straight sinus will be draining into the left side transverse sinus. And here is the torcula hieroferi, which is the confluence of sinuses. So we can see the circulation in the brain, like it starts from the cortical veins, and it will go to the superior sagittal sinus. From the superior sagittal sinus, the blood will reach the confluence of sinus and turn towards the right transverse sinus, which will continue into the sigmoid sinus, and finally into the interjugular vein. Similarly, the occipital sinus will also drain up towards the confluence of sinuses, from there towards the transverse sinus into the sigmoid sinus, whereas the inferior sagittal sinus will drain to the straight sinus, going from straight sinus to the left transverse sinus, and ultimately draining to the sigmoid sinus into the internal jugular vein. So this is a schematic diagram of how the surface of the brain with the various cortical veins looks like. So here there are two important veins that we need to understand: the vein of Trollard and the vein of Labbé. These are actually the communicating veins. The communicating veins between the superior sagittal sinus and the superficial middle cerebral vein is known as the vein of Trollard, whereas the communicating sinus between the superficial middle cerebral vein and the transverse sinus is known as the vein of Labbé. These are one of the most important veins to maintain the circulation between the superior sagittal sinus and through the superficial middle cerebral vein. This superficial middle cerebral vein will ultimately drain into the cavernous sinus. So these veins are kind of communication between the sagittal sinus and the cavernous sinus. So here is a MRV diagram of how the sinuses will appear. So here we can see the superior sagittal sinus. Lateral sinus is also known as the transverse sinus. Here is a straight sinus, internal cerebral veins, and the basal vein of Rosenthal joining into the internal cerebral veins to form the great vein of Galen. This is a DSA image which shows the inferior sagittal sinus, superior sagittal sinus, straight sinus, vein of Galen, basal vein of Rosenthal, and this is the transverse sinus joining to the sigmoid sinus. So coming to how the this cerebral venous sinus thrombosis, depending on the venous sinus which is involved, will cause what kind of symptoms. So we know that the superior sagittal sinus will be draining the cortical surface. So as a result, the patient is likely to present with a motor deficit or seizures. Similarly, the inferior sagittal sinus can also present with motor deficits and seizures. Straight sinus, since it will be draining the internal cerebral vein and the basal vein of Rosenthal, it is likely that it will present with infarcts in the thalamus. So as a result, the patient will have motor deficits as well as mental status change. When it comes to the transverse sinus, it will be usually involving a temporal lobe. So as a result, the patient will have headache. When it involves the drainage of the posterior fossa veins and the tentorial veins, it will cause tinnitus as well as cranial nerve palsies. When internal jugular vein is involved, it will cause neck pain, tinnitus, and cranial nerve palsies. So these are the kind of presentation the patient will have depending on the sinus involvement. How we will diagnose on radiology? So this is a non-contrast plain CT of a patient who has right transverse sinus thrombosis. So here we can see, compared to the left side, the right side transverse sinus appears hyperdense. This sign is known as cord sign. Any cortical vein or a cerebral venous sinus which is thrombosed will appear hyperdense on non-contrast CT. The same thing can be seen in a straight sinus on this in this patient. This is known as the dense vein sign. When we do a CT contrast of the same patient, we will see a filling defect into the straight sinus as well as in the sagittal sinus, both of which appear hyperdense on the plain CT, will be appearing non-contrast enhancing on a contrast CT. This is known as dense vein sign. Coming to the sign which is very well known in cerebral venous sinus thrombosis, this is the empty delta sign. So here it's a delayed CT contrast image which is showing that there is a thrombus into the superior sagittal sinus, which is seen as hypodense in contrast CT. Similarly, this is an axial image where there is a hypodensity within the superior sagittal sinus, which suggests that there is block of the superior sagittal sinus. Not able to show the MRI, but in MRI, we can see on a T1 weighted image, the sinus will appear hyper intense, and the hemorrhagic infarcts can be seen as hyper intense on plain T1 image. So that is diagnostic of a cerebral venous sinus thrombosis. Now coming, I'll hand over the next few slides about the management and etiopathogenesis of cerebral venous sinus thrombosis to Dr. Prachi.
Hi, my slides are visible?
Yes, they are.
Okay, so good evening, everyone. I'm Dr. Prachi, and I'd like to thank the organizing team for giving me this opportunity. Before I go ahead with the pathophysiology, just a quick word about the epidemiology of CVT. See, the overall incidence of CVT is 0.5 to 1%, so it's a rare cause of stroke, but it actually contributes significantly to the burden of stroke amongst the young demographics of the Asian population and the developing nations. Secondly, what is important to know is that despite having an overall good prognosis, it is said that more than 80% of the patients will eventually attain independent survival. Identifying those patients who will actually have a poor prognosis is very difficult in these patients. Plus, if severe diffuse CVT is left untreated, it may lead to a mortality of as high as 10 to 15%. So when we talk about the pathophysiology of CVT, there are two main pathophysiological mechanisms in these cases. First is the thrombosis of the venous outflow tracks your cerebral veins and the venous sinuses, and second is the reduced CSF absorption. So what happens is when there is a thrombosis of the cerebral veins and the venous sinuses, it will lead to a progressive increase in the capillary and the venular pressure as well as the venous pressure. So this will give rise to venular and capillary rupture, which will present as parenchymal hemorrhage. There will be a reduced capillary perfusion. The increased venous pressure will of absorption from the arachnoid villi and the granulations. This predisposes to intracranial hypertension. Eventually, blood-brain barrier disruption sets in because of this intracranial hypertension, which leads to vasogenic edema. All of this will culminate into a reduction in the cerebral perfusion, leading to ischemic injury and cytotoxic edema. So what is happening is there is a vicious cycle which is getting generated. Initially, there is a decrease in the local cerebral blood flow, which leads to local ischemia, which predisposes to cytotoxic edema. Then there will be a disruption of blood-brain barrier and vasogenic edema. So your initial insult, it basically continues to progress. Another important thing to understand in the pathophysiology of CVT is that, as Dr. Keyur mentioned, these sinuses are triangular dural reflections, which are prone to compression and distension, right? Because they don't have a muscular wall as your arterial circulation. So when there is a blockage of the venous drainage system, the efferent venous flow that will fail to match the afferent inflow from the arteries. So there will be an immediate and dramatic change in the intracranial volume and pressure relationship, because ICP will be affected more by changes in the vascular pressure from the venous side than from the arterial side, because resistance is present on the arterial side and the venous channels are your capacitance vessels. So what is happening is there is a diffuse brain swelling which has happened because of CVT, which is causing further compression of the venules and of the venous sinuses. So an internal Starling resistor kind of circuit develops, where there is an uncoupling of flow from the downstream pressure. So there is venous hypertension, which is leading to more swelling, which is leading to more compression, which is leading to more venous hypertension. So this has also been proven clinically. When you consider, like Dr. Keyur said, there is a superior sagittal sinus and then there are your deep cerebral veins. So if the superior sagittal sinus sway is blocked, the deep cerebral veins will act as collaterals as the communication between the superior sinus and the cavernous sinus. So it's understandable that the flow here might increase. So if we look at serial venous TCD recordings in such cases, here in the first recording, the ICP of the patient was 15 millimeters of mercury. In the second recording, it was 25 millimeters of mercury. And in the third recording, it was 35 millimeters of mercury. So the venous pressure changes in the collaterals were increasing as the ICP was increasing. Another important thing to know is the risk factors which are associated with CVT. So there are various prothrombotic states, both genetic and acquired. Specifically, I'd like to mention pregnancy and the postpartum state in the acquired prothrombotic conditions. Besides the drugs, in particular, oral contraceptive pills have a prevalence of more than 50% for CVT. And this is probably the reason that combination of pregnancy, postpartum state, oral contraceptive pills, and hormone replacement therapy, which leads to CVT being more common in females compared to males. Besides that, various autoimmune and inflammatory disorders, various infections, including as well as extracranial infections like mastoiditis and sinusitis, various medical and surgical causes, for example, certain neurosurgical procedures or trauma to the cerebral sinuses, malignancy-related causes, and dehydration are other common risk factors for the development of CVT. So why these risk factors lead to the development of CVT is because they will affect the integrity of your Furcow's triad. So they will either affect the vascular wall patency, or they'll affect the blood flow, or they will affect the blood components. Symptomatology will depend upon the site and extent of the lesion, as Dr. Keyur mentioned. Besides that, the patient may develop with three types of syndromes. These may develop in an isolated form, or they may be combined form. So these are the syndrome of intracranial hypertension, which may present as either headache, papilloedema, or focal neurological syndromes, which may present with various focal neurological deficits, aphasia, or the patient may present with encephalopathy with altered level of consciousness and coma. Approximately 40% of the patients will present with acute stroke-like syndrome within 48 hours of onset. So why do we need to know this epidemiology and understand the pathophysiology is to identify when should we be alert and look for CVT as the cause of stroke in patients. So certain examples are, suppose there is a 32-year-old female who's admitted 4 weeks postpartum and is complaining of persistent atypical headache. or an elderly male with a previous history of DVT is now presenting with multiple hemorrhagic infarcts on CT, or there is an elderly female who's on hormone replacement therapy who now presents with a combination of seizures with stroke. With a stroke-like picture, or there is a young female who has recently been started on estrogen OC pills with altered level of consciousness and hemiparesis. Or some other examples are there is a patient who's presenting with eye symptoms following a recent history of sinusitis. So for the principles of ICU management, most commonly the patients who will present to us in the ICU with CVT are those who will have a moderate to severe degree of CVT. So the ICU management principles what we'll cover is we'll look at the medical management. We have to prevent various complications as well as infection control and nutrition. I'll be also talking about the various neuromonitoring devices that we can use in these cases. And obviously, as we can understand based on the pathophysiology, ICP reduction is important in these cases. So the management is broadly divided into specific and supportive. Specific includes anticoagulant therapy and endovascular treatment, and supportive includes we have to treat the cause, we have to control the ICP, and we have to go ahead with seizure control. So the rationale for or why anticoagulation is the standard of care is because it prevents the propagation of thrombus. It restores the drainage in the anterograde or the anterograde flow. It will salvage the brain tissue from permanent damage. It will prevent recurrent thromboembolism from developing, and it will also prevent the development of other venous thromboembolisms. For example, in CVT patients, the association of pulmonary embolism is said to be approximately 0.8 to 1.8%. So this is reiterated in the AHA-ASA scientific statement where they say once the diagnosis of CVT is confirmed, go ahead with anticoagulation using either IV heparin or subcutaneous low molecular heparin, irrespective of the presence of ICH. That is not a contraindication. The European Stroke Organization guidelines, which are more recent, they also recommend that in patients with acute CVT, heparin has to be used in therapeutic dosage and irrespective of the presence of ICH at baseline. And they also give a weak recommendation that you can treat patients of acute CVT with LMWH instead of unfractionated heparin. Obviously, this does not apply to patients who have developed vaccine-induced CVT, where non-heparin anticoagulation is warranted, and which is basically now important in the post-COVID era, where we saw a lot of increase in vaccine-induced CVTs after the use of various vaccinations like Covishield and AstraZeneca. So what happens, why we don't use heparin anticoagulation in vaccine-induced CVT is because the pathophysiology is very similar to heparin-induced thrombocytopenia, as there are antibodies against the platelet factor 4 and your polyanion complexes in these cases. So the evidence in favor of low molecular weight heparin over unfractionated heparin is actually pretty limited. There is a single meta-analysis which shows a non-significant trend of improvement in mortality and functional outcome favoring low molecular weight heparin over unfractionated heparin with no difference in extracranial hemorrhage. Why it goes in the favor of low molecular weight heparin is probably because of the fact that LMWH have not only a longer duration of action, but they have a more stable therapeutic action compared to unfractionated heparin, because unfractionated heparin has a non-linear dose response effect, and therefore there is an increased risk of underdosing and overdosing. Besides that, for LMWH, there is the ease of administration, and you don't require regular lab monitoring, which are added advantages. On the other hand, unfractionated heparin may still be considered in certain situations. For example, when you need rapid normalization of APTT, when you are expecting complications of anticoagulation, or when you're expecting that the patient may require emergency surgical intervention. So the dosage is our full therapeutic dosage. For unfractionated heparin, you give an initial bolus of 80 units per kg, followed by an infusion of 18 units per kg per hour, which can be guided by your APTT values, which can be repeated 4th to 6th hourly. For low molecular weight heparin, enoxaparin dose is 1 mg per kg BD, and dalteparin dose is 100 international units per kg BD. So for how long should you continue anticoagulation? Suppose there is a patient who does not have any medical condition which is associated with a high risk of recurrence. In these cases, guidelines recommend at least continuing for 3 to 12 months, depending upon the cause. On the other hand, if there are patients who are presenting with unprovoked CVT, for example, there's a patient who's presenting natively with CVT and does not have any associated prothrombotic condition, does not have any associated transient risk factor for CVT. In such cases, or in cases who have recurrent venous thromboembolism, or those who have associated prothrombotic conditions, in them indefinite or lifelong anticoagulation will be required. What is important to know is for pregnancy and postpartum state, low molecular weight heparin is recommended, and this should be continued for at least 6 weeks postpartum and for a total of 6 months. And obviously, in these cases, warfarin is not to be administered because of the increased risk of teratogenicity and the risk of fetal losses and spontaneous abortions and fetal bleeding. So next is the newer oral anticoagulants or the directly acting oral anticoagulants in comparison with warfarin. So the evidence for these comes from two large trials. First is the RESPECT CVT and second is the ACTION CVT. So for RESPECT CVT, patients received parenteral heparin for 5 to 15 days, after which they were randomized either to receive dabigatran 150 mg BD or warfarin based on the INR targets. This was continued, and then the patients were followed up for 6 months. So they found that there was no difference in the incidence of recurrent venous thromboembolism in both the groups. There was one major bleeding event in the dabigatran group compared with two in the warfarin group. In the warfarin group, there was also a clinically relevant non-major bleed, and the recanalization rate was also similar. It occurred in 33 patients in dabigatran compared with 35 patients in the warfarin group. Therefore, the RESPECT CVT offered published evidence favoring or at least highlighting the utility of direct oral anticoagulants for CVT cases. The more recent study, which has been published in 2022, is the ACTION CVT study. This was a multi-center retrospective study which looked at patients who received either the DOACs or warfarin in CVT cases. The majority of the patients, they received rivaroxaban, apixaban, and some also received dabigatran. So here they found that again, the risk of recurrent venous thromboembolism as well as mortality and the rate of recanalization was similar between the groups. However, what they found was that there was a lower risk of major hemorrhage with the DOACs compared to warfarin, favoring the use of DOACs. So once you've confirmed CVT and you have started the anticoagulation, you see if the patient deteriorates with respect to the consciousness level, is the patient developing progressing deficits, is the patient having worsening seizures. If yes, then the patient is labeled as a heparin non-responder. Then you have two treatment options. Either you go ahead with endovascular treatment, or if the patient has a mass effect or refractory intracranial hypertension with increasing midline shift, with increasing cerebral edema, or with increasing intracerebral hemorrhage, then you go ahead with decompressive craniectomy. So for endovascular therapies, there are two main options. So there's either local thrombolysis, or you can go ahead with mechanical thrombectomy. So various regimens are available in literature, either with the use of RTPA or urokinase. For mechanical thrombectomy, also stent retrievers, suction catheters, penumbra catheter, and balloon catheters have been used. So the proponents of endovascular therapies, they actually say that when you are able to achieve recanalization with an endovascular therapy, it will have an immediate impact on the cerebral venous drainage, which will reduce the ICP, and that will also facilitate the action of anticoagulants. Therefore, this may be better compared with medical therapy alone. Especially in patients who have risk factors for a poor outcome in them, it may prevent thrombosis progression, reduce the risk of new intracerebral hemorrhages, and therefore decrease the morbidity and mortality. However, most of this evidence comes from small studies or case series only, and the only RCT looking at this is the TOAC study, which is a thrombolysis or anticoagulation for CVT. Here, the patients were randomized to receive either EVD-based medical care or medical care alone based on the guideline recommendations. So they found that so in the EVT group, they basically utilized mechanical thrombectomy, local thrombolysis, or a combination of both the strategies. And they found that the patients who attained good outcome in these groups were similar. It was 65% versus 66%. Also, there was no difference in the risk of mortality and the risk of hemorrhagic complications in both the groups. Therefore, the conclusion was that endovascular therapies, compared with standard of medical care, they do not appear to improve the functional outcome in patients with CVT. So if you look at the summary of evidence, currently the only indication of endovascular therapy is when there is a deterioration despite anticoagulation with severe neurological deficits and coma. However, how long you continue anticoagulation before you label it as a failure and proceed to EVT is not known. Which device to use, which approach to use also is not known. And the guidelines also recommend, though these guidelines came before the publication of two-act trial results, they also recommend that EVT should be used only when the patient is refractory to maximal medical management. So coming to neuromonitoring now, as I already mentioned in the pathophysiology, the rationale for neuromonitoring can be understood if we go back to the pathophysiological mechanisms. Because intracranial hypertension is the main cause of deterioration in these cases, ICP monitoring, and because subsequently there is ischemic injury and reduction in the cerebral perfusion, cerebral flow monitoring and cerebral oxygenation monitoring can be utilized in these cases. So if we look at the available literature for various monitors that have been used, this was a case which utilizes TCD in CVT cases by Weckerly et al. So what they did was they assessed the pulsatility index using TCD in these cases, and they found that as the patient's neurological condition deteriorated, the PI increased. So when the patient developed a deterioration in the neurological status and papilloedema, the PI was 1.93. So they escalated the therapy, and the patient was treated with endovascular intervention, after which the PI gradually reduced. And within 3 days post EVT, the PI was within normal values. And you can see that subsequently, once the papilloedema settled, the PI value has reduced from 1.93 to zero point 0.8. On the right side, what I have highlighted, as I mentioned previously, is the venous TCD picture of a normal individual. Because of the increase in the intracranial pressure, as I explained in the pathophysiology, we expect changes in the venous circulation, the deep cerebral veins as well. So this is a basal vein of Rosenthal. Usually for patients who have normal intracranial hemodynamics, mean flow velocities are usually less than 30 centimeters per second, and the pulsatility index is low. And we can identify the basal vein of Rosenthal as it lies because of its close proximity to the PCA, the P1 and the P2 PCA. So for transcranial venous Doppler, the findings that are reported in literature on CVT patients are there will be a pathological increase in the blood flow velocity in the deep cerebral veins which are involved in the collateral outflow. If there are paired deep veins, there will be an asymmetry of the blood flow velocity, usually more than 50%, and there may be a reversal of blood flow in the collateral venous circulation. Similarly, optic nerve sheath diameter can be utilized in CVT cases. This again, there are only case reports highlighting the use of ONST. So ONST can be used as an indicator, as a dynamic indicator of elevation of ICP. In this case report, there were two patients. One was with venous sinus stenosis, another was with venous sinus thrombosis. And they found that initially the ICP was high, and post-intervention, there were dynamic changes in the ICP, which reduced as assessed using the optic nerve sheath diameter. There are other case reports which have combined both pulsatility index used from TCD and the ONST for identification of raised ICP CVT patients. Regional cerebral oxygen saturation can also be utilized in CVT because oxygenation impairment is one of the pathophysiological mechanisms for the deterioration here. So in this study, which was done by Venkateshwaran et al., they looked at NIRS-derived regional cerebral oxygenation saturation values in patients with malignant CVT, and they found that the patients actually had a lower value on the side of the lesion, and after the patient underwent decompressive craniectomy, this value improved significantly. So they proposed that what is happening is probably with the reduction in the intracranial pressure, the perfusion is improving, and because of that, the RSO2 values have gone up. However, having said that, we need to understand that NIRS, as a regional cerebral oxygen saturation monitor, has a number of limitations when we consider its use in CVT patients. One is there are a number of confounders which can affect its utility. For example, hemoglobin values will affect the value of NIRS, and we know that both polycythemia and anemia are known risk factors for CVT cases. Second is the sensor may not read accurately because of an underlying hematoma or because of underlying tissue edema. And thirdly, the pathology may actually be distant from the site that the sensor, site of placement of the sensor. Another important thing to consider in the clinical management actually of CVT patients is that, as I mentioned, what is happening is if we go back, if we revise the pathophysiology of CVT, there is a disruption of the capillaries and the venues and then the arterioles. So these are the main effector organs of autoregulation that we know. So autoregulatory capacity is expected to be disrupted in CVT cases. So in the study, which has been it was published in 2020 or 21, they have compared CVT patients with controls, and they found that patients with CVT were more likely to have impaired cerebral autoregulation, and not only on the ipsilateral side to the lesion, but also the contralateral side, which highlights that there is a higher burden of disease because of the global increase in ICP in these cases. So in clinical practice, this becomes important because if you do not control the blood pressure, if the blood pressure increases and the autoregulation is disrupted, it will give rise to an increase in the hypoperfusion. It will predispose to hypoperfusion, which will eventually predispose to increased ICP, therefore may affect the patient outcomes. So overall, in the neurocritical care setup, if we are not using invasive approaches in CVT, which may be difficult because of the anticoagulation, multimodal non-invasive approach can at least be used, where we can combine non-invasive measurement of ICP with ONST and transcranial Doppler-derived changes in diastolic velocity or versatility index, TCD-derived assessment of autoregulation. We can utilize NIRS as well to some extent, and bispectral index, though I did not find any study for this, it can also be used because in other acute brain injury cases, it has been shown to basically identify the electrical activity of the functioning neurons and has been used to predict the recovery of consciousness in various patients with similar pathophysiological mechanisms of raised intracranial pressure. So this is an example of multimodal invasive regional monitoring in severe cerebral venous sinus thrombosis patients. Two patients were studied, and in them PbTO2, ICP, and microdialysis catheters were placed. So these patients, despite being on anticoagulation and having almost normal values of ICP and PbTO2, continued to have worsening microdialysis values, microdialysis derived values. So the patients underwent mechanical thrombectomy because of these microdialysis based values. And after that, the PbTO2 and the ICP significantly improved, but more importantly, the lactic levels, glutamate levels, and the glucose levels also significantly improved, highlighting that regional ischemia actually can be identified in CVT cases. Another important aspect to be considered in the management of CVT patients is the seizure prophylaxis, because CVT is the seizures are most frequently seen in CVT than any other type of stroke because of the cortical involvement. The incidence may be as high as 40%, and certain risk factors which have been identified for the development of seizures are the supratentorial location and the patient presenting with an initial seizure. So both the AHA and the European guidelines, they say that if the patient has a parenchymal lesion or if the patient is presenting with seizure on presentation, then go ahead with seizure prophylaxis. It can be continued up to a year. And a more recent recommendation is anti-epileptic medications can be tapered off after 3 to 6 months if no further seizures occur. So in our institute, what we used to do is seizure prophylaxis was usually continued for up to 2 years, at which point an EEG was repeated to rule out any IEDs, and then it was stopped. Next important thing is the management of intracranial hypertension in these cases. So the goals of intracranial hypertension remain the same as in any other patient who's developing ICP. We need to prevent secondary brain injury. However, the main factor which will reduce the ICP here remains anticoagulation, because that will reduce the clot burden. Besides that, various other supportive measures can be used. There are no RCTs which have compared which measure is better for CVT patients. So you can go ahead, give the patient head and elevation, sedation and analgesia, ensure that the CPP is maintained according to the autoregulatory status, ensure there's no anormocapnia, and if the patient continues to worsen, then increase your osmotherapy or go ahead with mild hypocapnia, and basically buy time before you go ahead with decompressive craniectomy. So the ESO recommendations currently do not suggest the use of therapeutic lumbar puncture, acetazolamide or diuretics, steroids, and shunt without other surgical interventions to improve the outcome of the patients and to reduce the risk of mortality. Having said that, they say that steroids may be used in patients who are presenting with acute CVT due to Behçet's disease and other inflammatory diseases like SLE, where it has been shown to improve outcome. And even for acetazolamide and therapeutic lumbar puncture, they give an additional remark that if the patient is having an isolated intracranial hypertension syndrome and there is a risk of vision loss in those patients, or there is very severe persistent headache, then these two maneuvers can be considered. For decompressive craniectomy, it is recommended in acute CVT, especially when there is impending herniation to prevent death. And for talking on decompressive craniectomy, since we have a surgeon amongst us, I think I'll hand it over to him. Dr. Keyur, please take it.
So thank you. That was very informative. We will go ahead with the next part of the presentation, which so surgery for cerebral venous sinus thrombosis that we will talk about today is decompressive craniectomy. So the indications for decompressive craniectomy is, as Dr. Prachi mentioned, it is malignant cerebral venous sinus thrombosis, with supratentorial hemorrhagic lesions and severe cerebral edema, and all the aggressive medical measurements have failed to control ICP, and decompressive craniectomy is thus required. Clinically, in such patients, we see that the patients has developed pupillary asymmetry causing third nerve palsy with ptosis. Sometimes even bradycardia and hypertension may be an indication to go ahead with the surgery, and sometimes even drop in sensorium. Radiologically, we have to confirm about these clinical signs, saying that patient has developed uncal herniation, midline shift of more than 5 mm, and a PCA territory infarct due to herniation. If we are measuring ICP, then persistent ICP levels about 20, some guidelines say even more than 25 centimeter of CSF, despite medical management. In that cases, decompressive craniectomy is required. We can see that the hemorrhagic infarct, which is present in this patient, where there is a left side parieto-occipital hemorrhagic infarct, has actually increased in the post-operative scan with a significant extracranial cerebral herniation. This can be seen in patients with CVT, and decompressive craniectomy for CVT is an extremely uh, fast and a messy surgery, because there is severe brain bulge, there is lot of ooze because of back pressure changes, all the emissary veins and the venous sinuses are blocked. So as a result, more and more bleeding is expected from the scalp, from the surface of the bone, from the pericranium, from under the muscle. So and we already know that these patients are having the risk factor of anemia, and they are sometimes even they are postpartum. So keeping the blood, keeping the pressures while we are doing this surgery is extremely important, because once we go into the stage of irreversible hypotension and it is not responding to fluids and blood, then the patient really uh, succumbs. So this is a flowchart outlining the management of CVT. We can see the once we have proven that the therapeutic anticoagulation, intensive care management is not helping us with the reduction of the edema, we finally go ahead with a decompressive craniectomy. And as I discussed earlier, in this midline shift, herniation and PCI infarct are one of the most important indications to go ahead with a decompressive craniectomy. So these are the various studies which has evaluated the role of decompressive craniectomy in CVT patients. And in the earlier studies, and before 2010, we could see that amongst the patients who were operated, uh, a majority of the fractions, like in 69 patients, 11 patients died, 34 patients, 4 patients died, in 44 9 patients died. But in the recent studies, you can see the deaths have decreased from 58, 8 patients have died, and in 17 patients in the one more study which Dr. Prachi also mentioned, Venkateshwaran, that only one patient died. So there is a recommendation of doing a decompressive craniectomy, but at the same time, because of the ICU management and the medical management, these patients are surviving as a result of this significant uh, complications of the surgery, and they are not succumb. These are the various options that we have for a decompressive craniectomy. The options is if it is involving one side frontal and parietal lobe, which is seen in superior sagittal sinus thrombosis. So whichever side has more mass effect and midline shift, we will go ahead with a frontotemporoparietal decompressive craniectomy. If it involves the transverse sinus or a posterior part of the sigmoid sinus or the torcular region, in that case we consider for temporoparieto-occipital decompressive craniectomy, TPOD. This is one of the most common decompressive craniectomies done for CVT. Sometimes the entire hemisphere is having infarct. Then in that case, we might have to consider for a T-shaped incision with a hemicraniectomy. So involving the fronto-temporoparieto-occipital region, and remove the entire bone on one side. Sometimes we have difficult cases of bilateral frontal hemorrhagic infarcts with central herniation. These patients require bifrontal decompressive craniectomy. But one bottom line for a decompressive craniectomy is the standard measurements, which should be at least 15 into 12 centimeter, which is common for even traumatic brain injury or malignant infarcts in stroke. So these are the different options, but size should at least be 15 into 12 centimeter. That is the baseline. We can see in this image that there is a thrombosis of this vein, and we can see that is the brain looks very angry. There is diffuse edema. It appears very red, and the brain is bulging outside the dura. There are release incisions given at the edge to give accommodate more space into the brain, and we cover the brain with a pericranial graft to avoid further post-op complications of decompressive craniectomy, like subgaleal bleeds, hematoma, hygroma, CSF leaks, as well as hydrocephalus. One important point about doing this decompressive craniectomy is to avoid the craniotomy edge near the midline or in near the sinuses, because the sinuses are already blocked. They are at risk, and if we injure the sinuses, then the anticoagulant therapy will also not help. And at the same time, these sinuses, if injured, can and cause long-term complications like hydrocephalus or subdural hygromas. So, what are the factors which are related to poor outcomes even after doing a decompressive craniectomy? Is like age more than 50 years. These old age patients are more friable, and they are more likely to lose more blood and become unstable during the surgery. Midline shift of more than 10 means there is a significant mass effect, and usually these are the cases which are taken late for surgery, and significant time has passed, and there is a significant injury. Total effacement of basal cistern, if there is no basal cistern seen at all, so we can expect a post-operative PCA infarct in these patients, or sometimes even white cerebellar sign in these patients. We find that in post-op period, if you use do a CT scan, and we find that the brain is black. Sometimes there is a deep venous involvement. So we discussed earlier that fall in GCS, third nerve palsy, is an indication to go ahead with surgery, but we have to be very careful that if it involves the torcular hierophili, and then it involves the inferior sagittal sinus, straight sinus, and intercerebral veins, in that case the patient will develop bilateral thalamic infarct. These patients are they are very poor in outcome based, and they usually succumb. So decompressive craniectomy has no role in fall in sensorium due to deep venous involvement, and predominantly bilateral lesions, like I described earlier, when we go ahead with the bilateral frontoparietal hemorrhagic infarct with central herniations. These patients have poor outcomes after decompressive craniectomy as well. So, what are the complications that we see in a patient after doing a decompressive craniectomy? Is early is like, since the CVT is a progressive disease as described earlier, and we do not start anticoagulant therapy as early as 12 hours after the surgery, at least till 24 hours, and during this time the CVT is extending, and as a result the hemorrhagic infarct can further increase, so there can be hematoma expansion. Second thing is, when we release the dural compression, when we open up the dural spaces, these hematoma which was under pressure earlier may expand further. So it just give away to the veins, and as a result the pressure will increase. There can be external cerebral herniation. So when the brain herniates out of the outer table of the skull, so there is a compression of the veins against the craniotomy margin. Sometimes if the craniectomy is small, so these veins at the craniotomy margins will get compressed, and as a result they will further exponentially increase the edema, and then we can have a severe brain bulge intra-op, and there can be a lot of complications during the surgery. There can be wound complications, as I mentioned earlier, due to inadequate dural closure or difficult wound closure because of severe brain bulge. There can be CSF leak and CSF fistula. Sometimes because of this, there will be secondary post-operative infection, and some patients even developed brain abscess because of the hematoma which was lying inside, and as a result there was the infection spreading into the hematoma causing abscesses, and these patients have seizures and epilepsy in long run. So decompressive craniectomy, though a last resort, but it is full of complications and should be avoided till medical management is available. There are certain late and delayed complications of decompressive craniectomy, like subdural hygroma and hydrocephalus, as I described earlier. If you try to do a decompressive craniectomy within 2 or 2.5 centimeter of the midline or on midline, you will lose the arachnoid granulations, which are actually draining the CSF, and as a result the CSF circulation around the brain will decrease, and the patient will ultimately have hydrocephalus or subdural hygroma or pseudomeningocele. Sometimes when the intracranial pressure is subatmospheric, the extracranial atmospheric pressure will try to compress the brain, and then they can develop syndrome of Treffind with persistent headache and the flap going completely concave in the long run. So these are the several examples of the complications after the decompressive craniectomy. Here we can see there is a severe brain bulge with smaller craniectomy size, and the brain is getting compressed at the craniectomy margins. The same patients on long run, their hematoma got infected, and that hematoma developed an abscess. So which required surgical intervention in a longer run, and we had to drain this pus. This is another example of right side of FTP decompressive craniectomy for CVT, and then this patient has developed hydrocephalus after the surgery. This patient had involvement of superior sagittal sinus, so that is also one of the important factor which can cause hydrocephalus in a post-operative period at a delayed stage. So this patient underwent thecoperitoneal shunt and followed by replacement of the bone flap. Here is another example of the bone flap getting exposed and infected, and they can have significant abdominal wound issues, and we had to throw the bone flap and do a customized cranioplasty. And here is an example of bilateral decompressive craniectomy done for CVT, and this patient had syndrome of Treffind. We can see that the brain is getting compressed from both the sides, and after doing a cranioplasty, this patient actually improved. So we can see that the brain is expanded on both the sides, and the patient was fine. So take home messages: the decompressive craniectomy is a last option in a select patients, and with medically intractable mass effect and raised ICP, where herniation is an immediate risk. And in less severe cases, therapeutic anticoagulation with low molecular weight heparin and medical management of raised ICP seems reasonable.
So I'd just like to, ma'am, can we go back on that slide? I would just
Yeah.
like to give the take-home message after, yeah. So the take-home message from this talk is that the main treatment options are low molecular weight heparin and unfractionated heparin. Besides that, it's important to treat the underlying cause. You have to control the ICP and the seizures. Long-term anticoagulation, still everybody I spoke with, the neurologists are preferring warfarin because of the more experience that they have with warfarin. NOACs are, however, coming into the picture now. EVT is not the standard of care. It has to be used on a case-to-case basis when there is an indication and when there is um, refractory worsening or there's no response to the medical management. And if the patient is clinically unstable, then as neurocritical care physicians, we can utilize multimodal neuromonitoring approach. And if the patient develops impending herniation despite the medical management, then decompressive craniectomy may be life-saving. Thank you.
Thank, thank you, Dr. Keyur. Thank you, Dr. Prachi, for such a uh, vast discussion. I've covered almost every nook and corner of cerebral venous thrombosis. Dr. Keyur, I just have one question. Usually,
Yes.
when the patient come to the ER, they are very restless. So we have a CT venogram and we have MR venogram as well. So what do you choose and how do you go about it? What is your main deciding factor?
We always go ahead with a sedation, like we give a lorazepam or midazolam since the patient will be already intubated, so airway is secured, and we go about with a CT venogram. We don't go about with a MR venogram because in our setup, to get an MRI with
Slot.
an intubated
Mm.
patient, we need require an anesthetist in the middle of night, and the patient requires sedation monitoring during the MRI, which is a time consuming thing. So we usually avoid it. And CT venogram is pretty much as we described. There is enough evidence in CT scan that will help us to decide whether the sinuses are thrombosed or not, and what is the extent of the disease. So it can also help us decide the surgical indication to go ahead with the surgery or not.
Is there any extra edge of MR venogram over CT venogram?
CT venogram is more sensitive compared to the MR venogram if it is done without a contrast. If you do T1 GRE sequence with contrast, then the sensitivity matches it. However, doing a simple MRV based on the flow study, it is less sensitive than a CT contrast venogram.
So our choice will always, in an emergency setting, be a CT venogram. Okay, all right. And also during surgery, like you said, the brain, I mean, usually when we have an intracerebral hemorrhage case, even when there is a brain bulge, you try to go and evacuate the clots as much as possible, isn't it? So,
Yeah, I would like to.
whenever possible. Yeah. So, in
Yeah.
this case, do you even touch that?
So usually in a superior cerebral sinus or a transverse sinus thrombosis, we see that these hemorrhagic infarct, they are close to the midline, or they are over the motor cortex, or sometimes you are in the Wernicke's area or a posterior temporal region, or in occipital region. These are really eloquent areas, and if we go and try to evacuate the clot, and since we know that there is a continuous incoming blood from the artery and the veins are still not opened, going about and trying to remove these clots is not going to help, because the blood will reaccumulate. And second thing, in order to remove the clot, we'll have to do a cortisectomy, which will
Hmm.
be destruction of an eloquent cortex, which should be avoided. So we avoid trying to chase the clot, and instead just do a decompressive craniectomy and leave it, and later at a later stage the blood will resolve and it will be a prolencephalic cyst, and usually it will communicate with the ventricle. However, if the brain bulge is too much and it is difficult to even close the skin, then we might have to
A
resort to such
lobectomy.
intervention of doing a lobectomy, or removing the clot, just so that we can do the closure.
Also, you mentioned that DC should be the last option, but these kind of CVT patients, they do really well with DC. So, is there no role of, like, if a patient is just becoming an M5 from an M6, so would you like not do it
So drop
immediately,
in
or if a
sensorium.
patient? Definitely.
Yeah, so drop in sensorium with uncal herniation is an indication, but if you have a medical management available, if the patient is kept in ICU and you have an invasive ICP monitoring to manage this patient, you can actually avoid the surgery. But doing a prophylactic decompressive craniectomy in this patient will actually prevent starting of heparin for another 12 to 24 hours. Because if you don't give heparin, if you don't recanalize the sinus in this patient, the patient is not going to improve from there. Because unless the sinuses are open, the patient will not simply, we have to understand that it is not the mass effect which has made the patient M5. In that case, the outflow of the venous sinuses from the cerebral cortex is actually making the patient M5. If the patient is M3, M4, in that case the herniation, this is the decorticate or decerebrate position, then yes, we have to go ahead, jump in, and remove the bone flap to prevent the herniation related defects. So actually decompressive craniectomy is not helping in the management of CVT. It is
It's just
just
to relieve the ICP mainly. Okay, all right.
Yeah, I would
Uh,
like to add to that. So, what the recent literature that is coming up is that unless the patient is having impending herniation, you avoid decompressive craniectomy and you go ahead maybe with endovascular therapies. Because, as he mentioned, and as we saw earlier, the whole idea of managing ICP is that you halt the progression of the disease, for which you need to reduce the clot burden. So, endovascular therapies may be utilized in cases who continue to deteriorate neurologically,
Despite medical
focal
management.
neurological, yeah, despite this thing, and then maybe After that, if there is evidence of increasing midline shift and increasing cerebral edema on your scans, or a very refractory intracranial hypertension that is not improving, then maybe decompressive craniectomy should be utilized. Though definitely, decompressive craniectomy has been proven to be life-saving in such severe diffuse cases.
All right. Prachi, in the aspect of critical care management, so when would you start therapeutic anticoagulation for these patients after undergoing a decompressive craniectomy? Like you said, the
So it's a
recanalization
very
remains the
institution
most important.
Right. So it's a very institution specific practice, and none of the guidelines say that, yes, this is the time point at which post decompressive craniectomy you go ahead and you start your anticoagulants. What There is evidence from a meta analysis which has shown that it may be safely restarted 24 to 48 hours post decompressive craniectomy. And what I have seen in my institution is that even 12 hours post decompressive craniectomy, you can go ahead and start the prophylactic dose and then build up on that and increase it to a therapeutic dose. So it's been proven to be
Correct.
safe in a meta-analysis at 24 to
Okay,
48
so you
hours.
agree with Prachi, like you start the therapeutic anticoagulation itself 12 hours later, or you just start with prophylactic and then move over to therapeutic?
We usually practice a
Because
thing like
usually
we
the
remove a
surgeons
drain.
usually are very apprehensive about starting the anticoagulation immediately after the surgery.
Yeah, so that had been a practice we were avoiding till 24 hours till we hand it over to the neurologist. But now we are moving ahead with, like, within 12 hours we give a prophylactic dose, then remove the drain off, and then once the drain is out, you can go ahead with the therapeutic management. Because as long as the drain is inside, there is a risk, like when we take out the drain, again there can be a hemorrhage, and an extradural hematoma or a subgaleal hematoma can develop. So as soon as the drain is out, and we try to remove the drain within 24 hours.
Okay. Or would you like to do a CT to just see how the scan is and then start the therapeutic anticoagulation, or you like just directly start it?
We nowadays we are always doing a CT after the
CT before
decompression.
starting the therapeutic
Always,
anticoagulation.
always.
All right, all right. Prachi, one more question to you is, when do you do this thrombophilia workup? Is it during the acute setting when the patient has presented with CVT, or later when the patient comes in the OPD basis for the follow-up, or
So we don't do it immediately in the acute setup. So there is a routine panel and an extended panel that I've seen at my institute, usually only for patients who are presenting with unprovoked CVT when we are not finding transient causes like ossifilus or mastoiditis or some other infection or inflammatory condition, or if the patient is presenting with recurrent venous thromboembolism, has a previous history of CVT or DVT or pulmonary embolism, and conventional risk factors we have not found. In that case, we send the routine panel where we look at the peripheral smear, the folate levels, the homocysteine levels, sickle cell we rule out, APLA levels, and vitamin B12, and also the various autoimmune conditions. And after that, usually, if there is a recurrence, only then the extended panel is used, where factor 5 lead in and they are basically done. And it is not done immediately. Once the patient is coming for a follow-up after 1 year of an unprovoked CVT, we stop it. We stop the anticoagulation for approximately 12 weeks or 2 months, and then protein C, protein S, and antithrombin 3 are sent. So it's protein C, protein S, antithrombin 3. These are not routinely sent for all patients.
so basically we don't do it in the acute setting. We ask the patient to come little later when during the follow-up, and that is when we do the thrombophilic workup. Thank you so much. CVT, if treated very effectively and on time, it has a really good prognosis. Thank you, Dr. Keyur. Thank you, Dr. Prachi, for this vast information you have given us. Thank you so much.
Thank you. Thank you, ma'am.